his talk. He's going to talk about optic neuritis. He's joining us from Ali Prasad Institute, Vizag. He's a faculty pediatric ophthalmology and neuro-ophthalmology there. Virender?
Yeah, thank you so much, Dr. Rashmi. Thank you, everyone, and I hope my slides are visible.
Yes, it is visible.
Okay. I would like to begin by thanking AIOS, Dr. Rashmin and Dr. Partha Biswas for giving the opportunity to speak on this important topic, optic neuritis, what's new. We all know that optic neuritis is a continuously evolving field and so much work has happened in this. So I would like to cover this in the following sections. What are the new insights into the etiology? So, and what's based on that, what's new in recommendation in the workup? What's new coming up in the treatment? And what's new understanding in pediatric optic neuritis? And then what is the new spectrum, the increasing spectrum of understanding optic neuritis status post COVID-19 and COVID-19 vaccination. So we know that optic neuritis is primarily secondary to demyelination in majority of the cases. And although it can be isolated, but majority of them do have association with some systemic or a CNS neuroinflammatory syndrome. The most common being multiple sclerosis, acute disseminated encephalomyelitis, NMOSD, or myelin oligodendrocyte glycoprotein associated demyelinating disorder. Based on the availability of the serological tests available for the last decade or so, and there have been studies that are coming up. For example, the study from the Western literature that shows the incidence of various etiologies in optic neuritis. So they found that in the Onset County, over almost a decade long study, they found that while multiple sclerosis was still the most common etiology, idiopathic optic neuritis was second most common, but NMOSD and myelin oligodendrocyte associated demyelinating disorders accounted for about 9% of all optic neuritis. That is almost one of the 10 cases. And further, these are associated with more frequent recurrences and suboptimal visual outcomes. Similarly, the pediatric optic neuritis study, which was a prospective study carried out by Pediatric group, showed that, again, isolated optic neuritis was seen in only less than half of the patients, while the other etiologies accounted for nearly 50% of them. And among them, most common was MOG-associated optic neuritis. So both the studies are telling us that a large number of them do have a specific neuroinflammatory cause. And the pediatric optic neuritis study also showed that an association with immunological diagnosis was associated with a worse visual outcome. Therefore, this tells us that it is very important for all of us to understand that optic neuritis is just a manifestation, and we need to subclassify it according to the underlying neuroinflammatory syndrome. As the progression of the condition is different, they can be modified and they can have worse visual outcomes and recurrences. So, are there some clinical clues? There have been very good studies which have come up in the recent past, in the last couple of years especially. For example, the study by Hakohen and colleagues, which showed the classification of multiple sclerosis versus non-multiple sclerosis related optic neuritis. They found that multiple sclerosis was more frequently associated with young and adolescent females, and it was never associated with an edema-like presentation. So these are some important clinical clues that will give us a particular clue. The MOG-associated optic neuritis can have certain specific features. Clinically, presence of hemorrhages is never considered to be typical of optic neuritis. However, MOG-associated optic neuritis can have hemorrhages in the peripapillary area. They can have diffuse CNS dysfunction and seizures at the time of presentation. They can have area postrema-like syndrome, and they can have recurrences, but with relatively good outcomes. So these features, which are coming up in relation to optic neuritis, suggest a particular etiology with MOGAD. Further, the same group by Heko and others showed classical differences they observed in their series between MOG-associated optic neuritis and NMOSD. And they found that MOG-associated optic neuritis was associated in young children, and they had monophasic disseminated encephalomyelitis, whereas NMOSD was associated more frequently with clinically isolated syndrome other than optic neuritis. So although this study was primarily done in the children because MOG-associated optic neuritis is more frequently seen in the children. But similar differences, for example, presentation with clinically isolated syndrome other than optic neuritis will hold true even in the adults where MOG is also being reported. So based on this understanding, what are the current recommendations for the workup? Do we perform all investigations, neuroimaging, serology, CSF analysis, or there are some clues to decide? We can subclassify these workup into ocular workup as well as a systemic. Ocular one can be for documenting visual function and structural damage. Dr. Shikha already showed about the role of OCT. There can be role of VEP and OCT angiography in specific indications. We will cover it very briefly. As regards the systemic investigations, neuroimaging is possibly the most important. Let's see in little more detail. I'll cover it in this slide. The MRI has been shown to give specific clues to the underlying etiology. This schematic diagram published by Dutra and others in this radiographics article shows a very nice depiction. The multiple sclerosis related optic neuritis tends to involve one side more often. These tend to involve short segments of optic nerve involvement. Spinal cord involvement involves the white matter tracts and tends to be short segments of spinal cord involvement. The periventricular lesions and subcortical long white matter tracts can be affected in multiple sclerosis. In contrast, NMO-related optic neuritis tends to be bilateral, can involve optic chiasm, prechiasmatic optic nerve. Spinal cord lesions tend to involve more than 3 contiguous segments and can involve the central spinal canal also. And then there can be lesions in the periependymal areas where aquaporin antigen is located. In contrast, MOG-associated optic neuritis again tends to be bilateral, but tends to spare the optic chiasm. Again, spinal cord involvement is long segments, but tends to involve the caudal spinal canal, spinal cord. And then there can be multiple white matter lesions in the various areas of the brain and also in the area postrema. So these can be responsible for the constitutional symptoms as well. Given the role of neuroimaging, if we look at these features, it can also guide us to do a serological workup. I'm sorry. So given the pattern that you're observing, you can guide your serological workup, which can be very important in a country like ours where resources are limited. Further, the role of imaging cannot be overemphasized, that where the patients are having seronegative reports, but they do have specific features to tell that this could still be an NMOSD. And this has been adopted in the current guidelines for making a diagnosis of seronegative NMOSD. So to summarize, neuroimaging should be the first line investigation. It guides the subclassification of disease and guides further workup and also prognosis. We should all obtain MRI brain and orbits with contrast with special sequences for fat suppression and for fluid attenuated sequences for taking up periventricular lesions. MRI spine ideally in all patients, but especially if there is a recurrent disease. The role of OCT has already been covered by Dr. Shikha, and she already highlighted that it helps differentiate between different types of optic neuritis. It can detect subclinical pathology as well as can provide evidence of dissemination in time and space in patients with suspected multiple sclerosis. So I'll skip these slides, but just to tell that the degree of RNFL loss can also vary in each of these conditions. I would like to highlight the role of OCT angiography. It is not classically needed in a diagnosis of optic neuritis, but it can be useful, especially in patients with atypical features and at extremes of age. We see on the right side the NAION and on left side a papillitis. So coming to the OCT angio in NAION, we can observe that there is not only a rarefaction of the peripapillary capillary net, but also specific defects that can be observed. Whereas in optic neuritis, we see disc swelling, we see rarefaction of the peripapillary RNFL that might be observed, but usually there are no perfusion deficits that we observe in optic neuritis. So this is how it can be useful in making a differentiation. Coming to the treatment guidelines, ONTT still holds in classical patient, but in patients, even in a classical patient, the initial treatment can be guided by ONTT. However, it requires that at this point of time, majority of the patients do get a serological testing, and as well as about 5 days of initial IVMP therapy rather than 3 days. Further
Can you
management.
conclude?
Yeah, I'm about to conclude shortly. As regards the further treatment, after the initial phase of treatment, the further treatment is guided by the final diagnosis, and there is need for immunosuppression. There is again a very important study which tells that which patients will need immunosuppression. MS, definitely yes, because to prevent permanent disability. NMO, to prevent permanent disability and recurrences, and even a single episode can cause mark damage. And MOG optic neuritis, evidence is coming that about 1/3 of them only get recurrences. So for recurrent cases, yes, but in others it might be observed. There are various treatment options. Among them, plasmapheresis can be used for countering acute episodes, and IVIG again for acute episode. But there are other studies that are coming up for various monoclonal antibodies that can be used in patients with NMOSD. And finally, a word about optic neuritis following COVID-19 infection and vaccination. There have been multiple associations that are coming up, especially recurrences, which could be believed to be secondary to the immune response. And there are patients which are turning out to be negative for both NMO and MOG. So giving us a clue that maybe something direct relation to the infectious etiology could be there. We have to wait and watch about this. With this, I conclude the presentation. Thank you very much for a patient hearing. And I would like to invite you all for upcoming meeting on COVID-19 and eye diseases. We have a very good neuro-ophthalmology session. Hope some of you can join us. Thank you.
Thank you, Virender. Ramesh, would you like to comment?
Yeah. Thank you, Rashmin. Wonderful talk, Viru. Very nicely covered. I just had one comment and probably one question. We have a situation in India, many cases, we can get imaging. I think in the last 1 decade, imaging has become almost mandatory and we do get it. What happens for the biomarkers? Are you able to get in every patient or it's not possible? If you get, still there could be negative. Do you recommend treatment based on an imaging finding? Because whether the seronegativity is because of cell-based assay, there are a lot of things, it matters. What is your experience? This is one question, and I had one more comment after that.
Thank you very much, Dr. Ramesh. I think this is a very important point that the sensitivity of the test itself is low, and especially if it is not a cell-based assay. So, and cell-based assays are not easily available in India. So therefore, further on, as I was trying to speak in the presentation also, the neuroimaging does play a major role, and we should continue our treatment based on the strong clinical suspicion. And we should also subclassify as seronegative NMOSD or seronegative MOG. Possibly that's how I do.
Okay. Thank you, Viru. One more comment I had is, if you look at the last decade, we are, at least I am seeing, it's open to all the panelists, less and less of typical optic neuritis related to MS. We are seeing more and more of NMO and MOGAD, these kind of optic neuritis. So every patient, I think finally they are onto the NMO spectrum or the other, where long-term immunosuppression is required. If you don't, they will come with recurrence. If they have 1 or 2 recurrence, then your treatment for the immunosuppression will not be so much effective. Are we going to see one more change because of the COVID? In my practice, at least, I haven't seen so much change in the last 1 year with relation to optic neuritis. Are we expecting one more change in the profile of the optic neuritis in the next half decade or 1 decade? Just wanted to know from others. That's all I had. Thank you.